So hi guys, my name is Amsha. I'm a foundation year one doctor currently in the Yorkshire and Humberside deanery. So I'm working in northeast of the country, I guess. So the rotations that I've been in so far are orthopedics, anesthetics, and I'm currently working in general surgery. So yeah, that's basically about me, I guess.
Amazing. And what's the talk you'll be doing for us today?
Yeah, so today, as I've been in the anesthetic department previously, I thought it would be really interesting and super useful to do a talk on preparing for surgery. So, most of the times, as foundation year one doctors, when you'll be working, you'll most likely get one job that is in surgery. And a lot of the times, especially when you're on call, you'll be asked to prep patients for surgery, and it'll be quite difficult initially because you won't necessarily get the grasp of things, especially when starting off in a new job and rotation. So I just thought I'd do a generalized preparation for surgery presentation to obviously help with dealing with patients, especially in a very acute setting. And yeah, if you guys have any more questions throughout the presentation, just let me know, put it in the chat. I'll try my best to answer any questions throughout. And obviously, I'll pop by at the end as well for any questions. Sounds like a plan?
Perfect. Amazing. Thank you.
So just let me know whenever we can start. I think we'll wait like 5 more minutes. Is that okay?
Yeah,
Or
do you want to wait maybe 3 more minutes, make it a round number, and then
yeah, that's fine.
yeah, perfect. And anybody who joins in late, join when they can, and then join in when whatever stage you're at in your talk.
Fine.
Okay, it's just turned 22. So how about we start? I've not had anybody else in the waiting room anyway, so we'll start for everybody who's here.
Lovely. That's fine then. All right, here. So yeah, so today I'll be doing a talk on preparing for surgery. Right. So today we'll cover a small introduction as to what preparation for surgery is like, what the assessment includes, the management, and we'll do one brief patient case study. And also I'll put up all the links to the resources that I've used as well. So why do we actually do a peri-op assessment? So it's a crucial process that's aimed at like evaluating patients. And basically you want to optimize those patients for surgery, whether it be an elective case or an emergency case. And this is shown to improve outcomes and also reduce complications, especially post-operative complications. And it includes an array of things. So you have to do a very thorough medical history, a physical examination, and do targeted investigations that are obviously patient specific. It also helps us identify and manage any comorbidities that they may have actually been missed by the GP for such a long time. It also helps give an opportunity for patients to understand why they are having the surgery, and gives a bit more time to, go through the processes of what the surgery actually entails in case they haven't gone through it previously, and also helps us consent in a very proper manner. And more than anything, when you're looking at funding side of things for hospitals and the NHS, it reduces surgical cancellations, it improves resource utilization, and also enhances post-operative recovery. So what does the actual assessment include? So first things first, bread and butter of medical school, always start with the history. So get a thorough presenting complaint and actually look at the aspects of the disease or the condition that's actually requiring the surgery, and whether they understand why they are getting that surgery and how it will improve their outcome. And you want to look at if they've had any past surgical history as well, whether that even be dental work, whether that be any ophthalmological conditions, because usually ophthalmology is like a day case. It may not seem like a major surgery, but you just want to make sure to get every surgical history possible, even if they were an infant. So anesthetic history. So this is a bit more of the important part, being an anesthetist. You want to clarify what sort of anesthetics they've used. Can anyone let me know in the chat or shout out what sort of anesthetic methods we have? Anyone?
I don't think I.
That's all right.
Yeah, I can't see anything in the chat. Why don't you let us know?
Yep. So there's local anesthetic, generalized anesthetic, and also epidural and spinal. So these are the four main methods of anesthetics that's used. So you want to clarify, like usually a patient said, oh, I have had surgery, but they probably wouldn't have gone under general anesthetic. They've probably gone under local anesthetic. So you want to clarify what they've had and whether they've had any reaction to the method that was used as well. Apart from that, you want to look at the airway. And obviously a lot of general anesthetic patients, they would require intubation or some sort of endotracheal tube. So you want to see how difficult it would be to intubate them. And other major conditions that you need to be aware of in anesthetic history is malignant hyperthermia. It's a quite rare of a condition, but it's a severe reaction that patients can get to anesthetics where their body goes to high temperatures. Succinylmethonium apnea. This is a condition that tends to run in families. Succinylmethonium is not used that often. It's usually used for rapid anesthetic, meaning you need to sedate the patient rapidly, especially in super emergentical cases or in children, because with children, they kind of cannot respond to anesthetic that well. So they tend to use it in children to kind of just get them to sleep quicker. But they can get this condition where they can go apneic. And that's basically because of an enzyme deficiency that they have, where the succinylcholine doesn't get broken down properly. So that's something that you want to clarify. And obviously anaphylaxis. So continuing on, some medical history that you want to look out for. Once again, with the anesthetic, the main thing that you're kind of taking care of throughout surgery is the airway, breathing, and circulation aspect of the A2E assessment or of your bodily system. So respiratory, cardiovascular, neurological, and renal, these four body systems are super important to be optimized. So respiratory-wise, asthma and COPD, this will help us with whether they'll have any ventilation problems throughout the surgery, and obstructive sleep apnea as well. That will also tell us their tolerance. Cardiovascular-wise, hypertension, acute coronary syndrome, heart failure, any vascular diseases and arrhythmias, especially atrial fibrillation. You want to optimize all of these because once again, surgery is something, it's just another form of stress on your body. So you want to make sure that their baseline is well. Neurological wise as well, certain conditions to look out for: Parkinson's, epilepsy, because a lot of these medications that the patients take for Parkinson's and epilepsy, they're very time-specific medications. So you want to make sure they have all their medications before they go into surgery. And once again, any background neurological disorders. And renal-wise, obviously, your renal system, your kidneys, they're the ones that balance your fluids and electrolytes. So you want to make sure do they have any renal injury previous to the surgery. Continuing on, some other bodily systems that you want to look out for: gastrointestinal. Once again, a major thing when going under general anesthetic specifically is aspiration pneumonia. So a lot of patients with reflux disease, they could end up getting aspiration pneumonia purely because of not tolerating intubation. So want to look out for that, and any nausea and vomiting. Usually when we induce patients, we tend to give them some IV antiemetics to prevent this, especially when they're waking up. So look out for nausea and vomiting. Endocrine, same thing: diabetes and thyroid disease, especially Addison's, in terms of cortisol. As I said, surgery is a stress to your body, so you need to make sure that they can basically manage that stress. And Addison's disease is a condition where you need to give steroids because they have steroid insufficiency, and steroids is the one that helps you recover post-surgery. And musculoskeletal system wise, rheumatoid arthritis, osteoarthritis, and ankylosing spondylitis. So for these conditions, you want to think about the neck and the lower back. Neck, you want to be able to see if it's mobile enough to help aid with endotracheal tubation. And with the lower back, if you're thinking about spinal or epidural, you want to make sure that there's no skeletal deformity. And make sure if you are having a patient of childbearing age that they're not pregnant, or if they are thinking about pregnancy, and how the surgery can affect future pregnancies. So continuing on with the medical history, as I said, you want to check out for hereditary conditions, especially with the succinylcholine apnea in the family. Drug history-wise, any medications that they're on, and any allergies. Oftentimes, for a lot of the surgeries, we tend to give prophylactic antibiotics, usually intraoperatively. So make sure you note down what allergies they have and what the reaction they have to said medication. And social history-wise, you want to see smoking, alcohol, recreational drug use, and also the living situation. Depending on the surgery that they get, oftentimes they may need extra support. And if the living situation is not great, you may have to intervene with how you can support them post-operatively as well. So these are all things that you want to keep in mind. So the examination part of the assessment. As I said, the main thing is going under general anesthetic is to check if they have a mobile neck and if they have any dental work and how easy it can be to intubate the patient. So malempathy classification is something that we've often used in the anesthetic department. So each time when we go to see a patient before surgery, we always check the malempathy score to see if we'll have any difficulties during intubation. And we'll also check the thyromental distance and their BMI, because once again, with obstructive sleep apnea, these can give us ventilation issues. So you want to make sure you do all of that in specifically with the anesthetic examination. And as I mentioned before, back examination for any skeletal malformations. So anesthetists also do a generalized multi-system examination. So generally see what the GCS score is like. Usually if it's a trauma case where like the patient's coming in the ambulance, as soon as it's a GCS of 8, it's time to intubate. I'm sure all of you guys have learned that in med school. So you want to make sure what their baseline GCS is and how they've been after the anesthetic as well. You want to check their hands and their distal limbs for how their perfusion status is. So do a capillary refill time, check their pulses. Neck-wise, obviously their JVP and any carotid buoys. Chest, main important part of the examination. Check what the heart is doing like and also check their lungs and see if they have any infection, anything like that. So blood tests. So you want to do these blood tests that I mentioned on the slide as a baseline. So for full blood count, usually you want to check if they have any anemia. Once again, depending on the surgery, if it's a major surgery, you'll be expected to lose quite a bit of blood. So you want to make sure that they're not anemic currently. And also thrombocytopenia. So check their platelet levels because that's what's going to help with post-surgical recovery. So urea and electrolytes, once again, a baseline renal function. Your body is going through that stressful period and just added stress is not super great for the kidneys. So you want to be able to optimize the kidneys as much as you can preoperatively. Liver function tests as well. A lot of the medications that you're giving will be metabolized by the liver. So you need to establish a baseline liver function. Also, a lot of the patients post-operatively may also end up getting more medication. And same thing, if the liver's not doing too well, then it's probably not a great idea. Clotting factors, check for any deranged coagulations, coagulopathies that they have, any bleeding disorders or clotting disorders, and a group and save and cross match. So I'm not sure if you guys know what the difference between group and save and cross match is. Group and save is basically in the name, you're checking the patient's blood group and you're saving it for a later date should they need any blood. So they don't immediately need any blood, but it could be the fact that, oh, possibly you're thinking, this patient may lose quite a bit of blood, so it's just good to have some in the fridge. Whereas with cross match, is you need the blood immediately. So what they would do is take the blood sample and then they would match it with other blood samples that they already have and see if there's any cross reactivity. And then whichever blood sample that doesn't react or is compatible, they'll send it immediately. So cross match is kind of like a step in between group and save and wanting the major hemorrhage protocol. So I'm not sure if you guys know what the major hemorrhage protocol is. So if you're getting a patient that's like profusely bleeding, like bleeding out of every orifice, usually in the hospitals, we put out the major hemorrhage protocol where they bring O negative blood, which is basically blood that has like no antibodies. So it's the universal donor. Anyone can receive it. So it's a step in between. So with cross match, it takes a bit more time, but they will send the blood. So other tests that you want to do Everyone gets a baseline ECG. Once again, this is more to check for any atrial fibrillation, get their non-invasive blood pressure readings, possibly an echocardiogram if they have background heart failure, and if they have a pacemaker, just check what their pacemaker is doing. Respiratory conditions, especially with severe COPD, you want to get a baseline chest X-ray and spirometry as well. As I said, rule out pregnancy. Just obviously any intervention that you're going to do, it's another added stress to the body. So pregnancy is very, very, very important. Infection-wise, MRSA swabs, everyone gets that in the hospital. Usually we won't operate on a patient that has MRSA positive. We need to eradicate the MRSA before we send them off to theaters. And depending on what condition that the patient has, you want to do specific tests for those. So if the patient has hypothyroidism, check their thyroid function before sending them off to surgery. If they're diabetic, check their diabetic control before sending them off to surgery, and etc. So moving on from assessment to management, does anyone have any questions throughout before I do move on to the management portion? I'm assuming no so far, so I'll just move on to the management. So to optimize patients for surgery, fasting is really important. Every single time you book a patient for an emergency list in the hospital, the first question the anesthetist always asks is, has the patient been fasted? So there's a bit of rules for the fasting. So patients can't have any solid food for 6 hours. Pediatric patients, they can take breast milk up to 4 hours before surgery, and patients are allowed clear fluids up to 2 hours before surgery. And this is really important because of the risk of aspiration pneumonia. Really nasty thing to get rid of if you do get aspiration pneumonia. It takes weeks to months to clear up, and it's very hard to treat patients with aspiration pneumonia because they can deteriorate really quickly. So really, really, really important that you fast patients before surgery. And some of the medications to start that patients are routinely started on before surgeries. So low molecular weight heparin, enoxaparin, in other words, all patients who usually end up getting put on it, all surgical patients especially. And you just stop it the day before the surgery, but everyone gets put on that. Appropriate analgesic control studies have shown that if they have preoperative pain management, they tend to recover quite quick post-operatively. Antacids, once again, if you're thinking about the risk of aspiration, you want to minimize that. And it's worse to have acid as well in your lungs if you do aspirate. So make sure to put them on antacids. And antiemetics, in other words, anti-sickness medications, so cyclizine and ondansetron. Ondansetron, just be careful if the patient has a history of long QT. So just check their cardiac history quickly if you are thinking about prescribing them ondansetron. Other medications that you can start them on. So antibiotic prophylaxis tends to depend on case-to-case basis. So a lot of general surgery patients, which is the rotation that I'm in currently, we tend to put them on antibiotic prophylaxis. But in orthopedics, especially elective cases, patients weren't necessarily started on antibiotics pre-operatively. They were only started on it post-operatively. So check that with your trust. Anti-embolism stockings, if they cannot take enoxaparin. Any medications for acute anxiety, and also if they have loads of secretion, you can also give medications to reduce that. So medications to be stopped or altered. This is super important. Once again, this is to optimize them for surgery, and it's a question that you tend to get on MCQs quite often as well. So warfarin ideally is stopped 5 days before surgery. DOACs, direct oral anticoagulants such as apixaban, edoxaban, they tend to be stopped 24 hours before a minor surgery and 48 hours for major surgery. Enoxaparin, as I said, 24 hours, just stop it the day before. Heparin is 4 hours, it's quite short acting. And antiplatelets, ideally, you want to stop at 7 days. Usually aspirin, 75 milligrams. They tend to continue it because it's very cardioprotective. So it depends on a case-to-case basis. But ideally, you want to stop it 7 days before. Insulin, if the patient's like type 1 diabetic or even a type 2 diabetic that's insulin dependent, we stop the morning dose and we put them on a variable rate. So you just keep sucking their blood sugar levels and then titrate the insulin accordingly. Any other oral hypoglycemics, you avoid on the day of the operation and once again switch them on a variable rate insulin. Diuretics and ACE inhibitors, you avoid on the day of operation, especially ACE inhibitors. Once again, in a major surgery, you're expected to have quite a bit of blood loss, and that can tip you off into hypotension, which is obviously not good. So if they've already had diuretics and an ACE inhibitor, these are quite potent antihypertensives. So we tend to kind of stop them. It's better to have them on the slightly hypertensive side than on normal blood pressure side where they're expected to have a lower drop of blood pressure during the surgery. So just stop that in the morning. Long-term corticosteroids, you want to change it to the equivalent dose of hydrocortisone, usually given IV. And the combined oral contraceptive pill, you stop it 4 weeks before surgery because of the risk of PE and DVT post-surgery. And that also includes hormone replacement therapy that has estrogen. So medications do continue. As I said, cardiovascular medications, really important, antiarrhythmetics. Aspirin 75 milligrams, you can still continue that, but don't ever stop the cardiac medications. Antipsychotics, the other caveat for patients with psychosis, when they wake up from surgery, they can be severely psychotic. So make sure they get their antipsychotic medication. Parkinson's, once again, time-specific medication and relatively short acting. So you have to make sure that they get their Parkinson medications. Any inhalers, once again, to optimize the ventilation. Glaucoma, immunosuppressants, thyroid medication, once again, quite specific to the patient and the formulation that they get for their thyroid medication, but make sure that they get that because it's metabolism related, so you don't want to avoid any delays because of that. Anti-epileptics as well. So some of the scoring systems that we often use in the anesthetic department is the ASA score. And this basically tells us like sort of the severity of kind of what sort of risk that they have to the condition that they're presenting with. So like looking at the past medical history, the assessment, and the need for the surgery, an ASA score of 1 is that they're a normal, healthy patient. An ASA score of 4, which is often the ones that we tend to see. We tend to see a 3 and 4. They have severe systemic disease, so this usually tends to be severe COPD, heart failure. So all of these diseases that are a constant threat to life if it's not optimized properly. An example of 4 or 5 is a moribund patient not expected to survive without the operation. That would be an example of a AAA rupture. So that's like immediately you need to get them into surgery or else they will die. And the other scoring system that we use is surgical severity score. So this talks about the surgery itself and how severe of a surgery it is. So while I was in the orthopedic department, we always had a patient with surgical severity score of 4. Joint replacements were done all the time. It is a very major surgery. In the general surgery department that I'm in right now, I tend to see cases that are surgical severity score of 2, sometimes 4, but more so 2, or even 1. Like appendicitis is a super common presentation, so we do laparoscopic appendicectomy all the time. So moving on, I have one patient case, and I'm just going to follow through what we would do for this patient that's presenting. So we have a 67-year-old gentleman, and he's a retired school teacher, and he is coming into the peri-op assessment clinic for an elective right total hip replacement secondary to osteoarthritis. So history-wise, he has hypertension, type 2 diabetes that's diet controlled, ischemic heart disease, and this is due to an MI that he had 5 years ago with a stent put in place. He has a background chronic kidney disease stage 3A. He's an ex-smoker, and he has no allergies and no family history. The medications that he is taking is amlodipine 10 milligrams, atorvastatin 20 milligrams, aspirin 75 milligrams, and ramipril 5 milligrams. And his current functional status is that he can walk 50 to 100 meters with a stick before his hip pain kicks in. He lives independently. He has no falls. He has a very good tolerance to exercise, and he climbs 1 flight of stairs with rest. So on examination, on neck movement, it's a full range. His jaw opening is 3 finger breadths, and he has no dental work. He has a Mallampati score of 2, thyromental distance of more than 6 centimeters, which is really good, and a BMI of 28, and back examination is normal. And multi-system examination-wise, he has no concerns. As you can see, everything is normal. And investigations-wise, his full blood count, his hemoglobin levels normal. He has no current inflammatory markers that are raised. His urea and electrolytes are okay. The only thing to note of that is his eGFR is 55, which you would expect in CKD. LFTs, everything is normal. Clotting factors, there's nothing that are out of the ordinary. He's an O positive patient, and because he is going to go in for surgery, where we're expecting a lot of blood loss, we would usually request 2 units of red blood cells. Other investigations that you want to do, obviously with this patient, he has a cardiac history, so get a baseline ECG, which shows sinus rhythm and old inferior Q waves, which you would expect from a patient that did have an MI. He has hypertension, so check his blood pressure and see if it's well controlled, and in this case it is. And once again, with ischemic heart disease, they could develop heart failure, so do a baseline echocardiogram, and his ejection fraction is 55%, and he has mild hypokinesia of the inferior wall, which is just saying that his inferior wall is not moving as much, which you would also expect with a patient that did have a cardiac event such as a heart attack. Chest x-ray, the patient was an ex-smoker, so though it wasn't extensive history, you want to get a baseline chest x-ray, which shows clear lung fields and a normal heart size. And patient was diabetic, and it was diet controlled. So you never know if the type 2 diabetes has progressed and if he just hasn't been following it up with the GP. So to get a baseline, his HbA1c is 44, which is normal. So management for this patient, we get him admitted to the hospital. We stop his food 6 hours before surgery, and he's allowed clear fluids up to 2 hours. We usually start them on IV fluids as well, just to keep them very hydrated. Medications to be stopped, as I mentioned, ramipril, an ACE inhibitor, is very potent antihypertensive. So you have to stop that on the morning of the surgery. And medications to continue, amlodipine, atorvastatin, aspirin, these are all medications that are cardioprotective, so you can continue those. And in this patient, he would have an ASC score of 3 and a surgical severity score grade of 4. And that basically comes to the end of my presentation. These are just some of the references that I used for the presentation. And thank you so much for listening. And please use the QR codes mentioned to join our WhatsApp and any feedback that you can give me on the presentation.